I'd like to transition now to move us to our panel. We've walked through, I think, today, and it's been some pretty good discussion, I think some powerful information about walking us through the why of this process, moving into the how, the where and the what and the who. And now I think comes this next operative sort of question about, well, when would you do this and when is the right time? In order to help us answer some of that question, we're going to have the panelists come up. In the meantime, once you guys stand up, stretch, we'll have a panelist, we'll introduce that, and we'll field some questions from the audience. I think what we've demonstrated today is that we do have tools and we do have the ability, and we are making, I think, fairly robust progress. I'm very encouraged and thankful for the people who've helped us pull that together. But we have the ability to do that. This next portion of our topics today are to discuss this idea of the when. When should we do this? And this group of educated people is going to help us answer some of that question. So we'd like to field questions out of the audience, and if not, I'll supply a couple of those as we get going. I'd like to introduce Dr. Jim Souza at the very end. Jim's been around a long time. There's quite a story of Jim being my R2 when I was an intern, but we'll save that for another day. Next is Chris Roth, who is our incoming System Chief Operating Officer. Chris has been around for a long time. He was the Treasure Valley CEO prior to assuming this new position. Next to him is Dr. Werner, who you guys met yesterday, Dr. Coates, who you've already met, Jeff Taylor, and Dr. Fortune. So as we get moving down that process, anybody have a question or you want me to tee this off? So a couple of things then. I'd like to start this process in the when, and I'd like to pick on you just a little bit, Dr. Werner, because you came from this example of the Fairview Health System. And a lot of the audience today is board members. And in the Fairview example, the board's physician leadership, the process was not aligned in something to be successful. And I'd like you to give a couple of high-level comments about that, about the importance of lining up those groups in order to move this process forward, because it is very threatening, like we've talked about. So if you provide a couple of comments on that about how you have to line things up before you pull the trigger.
Thank you, Jeff, for starting with the easy questions. You're right that alignment is very important. It is easy to be seduced by the compelling logic of better quality for lower cost and serving our communities better. You know, when you look at just the raw verbiage, who would be against that? So it can seem compelling and straightforward and a little bit mom and apple pie. But I think as you've been doing over the last couple of days, the challenge of alignment is to really deeply understand what that will look and feel like in its execution. And to recognize that there will be many challenges, many things that are unexpected, a lot of vagueness and uncertainty in there, that you'll have to stay committed to each other and stay committed to the journey. Because it can seem as though you can do all of these great things and actually not have to change. But at the end of the day, you will have to fundamentally change. Very fundamentally change. And making sure that board, senior management, mid-level management, all physicians to the greatest degree possible are sharing in that journey and understanding of that complexity is very important. Maybe a little bit to the point of when. The when to start is when you're committed to that alignment. Not necessarily all have totally agreed yet, but you're committed that you're going to align around that agreement, because getting to the real depth of that agreement is a never-ending conversation. Even 2-3 years from now, you will still be having the alignment conversation, because it's that challenging and that difficult to stay focused and stay the journey.
Any questions coming out of that? Or should I'll follow up maybe just quickly with you, Chris. John.
To follow up on that, you talked yesterday about you kind of evolve up to 20% into value performance, and then you're in the yellow box and you've got to run across it and speed to the other end, or I may be misinterpreting it, but I think that's kind of the way.
Yeah, you got the gist, yeah.
Okay. I find that hard to visualize how that's going to happen, because it would seem to me we're going to have a way to evolve in it kind of gradually at the rate of speed our market will work with us. Because if we have major insurance companies that won't work with us on this, we can end up having to do some of both for a hell of a long time to come. And it's my impression down in Salt Lake that Intermountain Healthcare, that's the way they're doing it, and very successfully. And I just don't see how you can force this jump across at 20% that this is all you're going to do, because people like Blue Cross in our area may not go along with this for 9 years to come.
That's a fair comment. I think that you're right about the challenges. I may try to frame some thoughts in a particular way and make sure I adequately respond to your question. You know, this is a journey, not a destination, and it will stay a journey for quite some time. The metaphor that I've used in the past is we knew we were going west. We were not going north, we were not going south, we were going west. We did not know if we'd end in Seattle or San Diego, and we didn't know exactly what route we were going to take. And every day, success was showing up, continuing on the journey, without always knowing clarity of where that destination was going to end up. And I think that's part of the alignment and part of the robust commitment to have together. You will have to explore many different partnerships, some you haven't even conceived of yet, in order to continue to gain the necessary momentum. And you're right, there's some critical partnerships that can seem rate limiting, potentially, you know, a very large payer being just non-cooperative, and I have faced that in the past. Part of your challenge at that point will be how much you press the agenda, how much you continue to stay the first mover, and how much you continue to engage the community in a conversation that reframes the community level understanding that makes it, over time, a little less comfortable for the unwilling partner to stay unwilling, if that makes sense. You know, if you really start engaging your employer community about the journey that you want to be on, that you're willing to help, if not fully lead, the commitments that you're making in this room and have already made, and you start putting that into a public conversation that you're prepared to lead, it changes the environmental context in which your partners have to respond to you. And I think that's part of the leadership lift that you will gradually face. Hopefully that helped make some sense for you.
So maybe I can add some color to that as well. I think, you know, one, sort of as the chief financial officer of the organization, I have no interest in reducing our overall financial health as an organization. So where we focus our efforts, I think, is a key strategy, and that focus needs to be on patient populations where we have appropriate aligned contracts from a risk perspective. And so we have a lot of work to do, and we can't do it everywhere. So if we focus our efforts on those populations where we're aligned, we should be developing a better product, which more consumers will ultimately want. And this idea of, I'll call them high-performing, narrow network products is sort of the future. So to the extent that we can practice on smaller populations and get there quicker than most, then we'll have a more attractive product that others will want to have. And going forward, the idea of choice amongst the consumer population, that's really the battle that or the yet to be determined differentiating sort of strategy between sort of what we're offering, what we're proposing to offer in a high-performing narrow network, and what's been the tradition in the purchaser of insurance. And it was indicated yesterday that many across the country think that choice is still the best way to go. And I think until we start differentiating price significantly between choice and narrow network environments, which we want to be really good at doing a narrow network environment, and to the extent there's choice products, then the price associated with the choice products will need to be at an appropriate level where we're appropriately compensated for the work that we do. And so I think that's the balance that we're going to have going forward, is how to manage that, but we have to manage it in a manner where we don't sort of reduce our overall financial health as an organization.
Thanks, Geoff. Other questions? John, hang on, Mike's.
Taylor, but what do you think an idealized payer relationship looks like? And I'd sort of like the physician's perspective as well. What do those partnerships look like, or in some cases, are we destined to be potentially a competitor with the payer? So I'd like insights on that. And I have a second question too, if I can have it.
So do you want me to go first on that, John?
Yeah, the first one.
Well, I think, if you remember that two-bar chart that we showed earlier in my presentation, we understand that, it takes money to finance risk, and there needs to be an appropriate bucket of money somewhere to finance that risk. The question is how big does that need to be? And so if we can come to agreement on that all parties in the equation need an appropriate return, and the end result of our strategy is to deliver a lower cost product at the PM level, as seen in the premium, then working with the payer that has that aligned commitment is what I would characterize as a strong commitment with the payer. Now, I also indicated that we don't have the balance sheet to take on significant risk as an organization. And the payer community, they have a balance sheet to do that. That's how they're organized and designed. So to the extent we have mutual respect of each other's capabilities and use each other's capabilities and competencies appropriately, that's the kind of relationship I want. So that's what we're striving to do with all payers. In fact, we're having significant discussions with all payers to get to that point.
Jim, what do you think the idealized payer relationship looks like from a doc perspective?
I think it probably would be different for different doctors, or it could be. I think some will be willing and interested in full risk, and some may be willing just to do sort of shared savings type models, and I think some will want to stick with fee-for-service and just contract. But I think we're not at a point yet in the physician community where there's a lot of, we're not unanimous in that.
Steve?
Speaking from a, just a standpoint of a practicing physician, any physician here, if you ask what are the hassles that you get from, from working with insurers, and a lot of them are going to tell you prior authorizations. They're going to tell you the formularies that you may or may not agree with. So in a good, from a provider's perspective, if there was a way that the providers could guarantee that there is a process in place that, for instance, advanced imaging is done via a protocol that the insurer could agree to, that would eliminate the prior authorization process under that diagnosis, that would be a huge help to the providers and hopefully a big win for the insurers, so that you can guarantee appropriate utilization. The other piece would be working together and being, honest and transparent, so that the robust data that our insurer partners are getting is shared with us, so that we can use that to improve patient care.
Brian, how about you?
I don't think you can underscore enough the need for trust and transparency. We have some insurer partners that have been very good about sharing data, and we're really grateful for that, because that allows us to have insight into our care in a way that we couldn't without the claims data. A lot of our clinical data you saw is outstanding, but without the insured data, there's still some holes in it. And the other thing is the insurers have a lot of programs with care management and with their pharmacy benefit design that I don't think physicians really trust very well. And if we could develop better relationships, so as an example, I sit on the Blue Cross P&T committee, and there's a very well-designed, thoughtful, evidence-based approach to their formulary decisions. It's not just about not wanting to pay money, and it's not just about requiring more prior authorizations. But I think if physicians could start to endorse that and understand that and use that as a way to help make better clinical decisions. And at the same time, the insurers could work with the physicians to obviate the need for some of these encumbrances like the prior authorization and what have you. So if that trust relationship were to work better, I think you could have a lot of efficiencies. And then I mentioned it earlier, or alluded to it with the HCC coding. If the work that we do, or any of us do, provides value, but it accrues only to the benefit of somebody else, it's really hard to sustain that. Our chief of staff frequently says you can't build a business model on altruism. You have to have a little more to it than that. So to me, that trust relationship and that interdependence that could be possible, it's just very difficult because honestly, I mean, maybe I'm polarized on this, but I think the insurance and the providers, we haven't historically worked that well together.
So Chris, I kind of think about the hospital structure as a provider as well. I mean, it's a little bit different because of the significant preponderance of the governmental pay in the hospital setting, but weigh in on that a little bit about from this, a hospital perspective, what is an ideal payer relation?
Well, first of all, before I do that, I do need to correct you, Geoff. I'm privileged to be the incoming Chief Operating Officer of the health system to succeed Gary Fletcher here in a couple months, and I've been fortunate to work under Gary, and he's served as my mentor for a number of years, and he's taught me, there are always three things. He always has 3 points when he wants to make a point. So I want to offer that answer in 3 points, and I always think of the why, the what, and the how, and I think Dr. Werner talked about the why, which is the mom and apple pie. We want to improve people's health in our region, i.e. population health, right? We all get that. There's not going to be argument. The what gets to be a little more challenging. The what we're talking about is a clinically integrated, narrow network delivering value that isn't seen in our community. And is that the horse that we're going to ride? And we're saying, yeah, that is. And then you talk about how. Once the what is out there and people believe in the what and they understand it, and I'll tell you, not everybody understands the what, not everybody agrees with the what. We have the leaders, we have the followers, we have the critics, and we have the cynics out there with the what. And then gets into the how, and this relates to perhaps hospitals and others, but we've talked about transparency, we've talked about data analytics, we've talked about reducing, eliminating variation that's unexplained clinical variation, standardizing formularies, eliminating silos. That's hard work. All the stuff we're talking about, incredibly hard work. And the concept of the network is that, be it a hospital, and we're saying St. Luke's Health System is part of the network. It is not the network. A hospital is part of a network. A clinic is part of a network. In other words, the delivery system, hospitals, clinics are operating at a level of performance that delivers value to the network as defined by the network. And we're going to find ourselves at cross purposes. And this all sounds great, but when we get down, I had a conversation last night with some physicians and say, well, what if our rate of imaging in the emergency departments start to go down? Well, how's that work in a fee-for-service environment? Revenues go down. How do the radiologists feel about that when that starts to occur? So I think that I believe we're on the right track. I believe it's the right strategy. I think at the end of the day, what's going to carry all of that is, one, leadership, and these 2 days are so critical to have the people in the room that we do. We have board members, community members, senior leadership. We have senior leadership from every major health plan in the area. Thank you all for being here, by the way. It's going to require leadership to do this hard work, and it's going to require a culture in our organization that supports it. I believe our culture in St. Luke's is at that tipping point where we're ready to work together. And again, the rubber's going to meet the roads there, whether it's hospitals or clinics. How do we start doing the same thing to reduce variation and eliminate the silos and find the areas of waste, the pockets of waste that Bob Locken talked about?
John, what was the second half of your question?
Yes.
Can you repeat
Is,
that a
is
little
there,
bit, John?
is there a difference in the way physicians are trained in terms of their looking at resources and how resources are consumed? And what do the physicians think the cultural changes that are required in training to actually get us to a different place in the delivery of healthcare?
Okay, I'll speak to that real quickly. Just for those in the room, I trained at the Kaiser Fontana, which is in Southern California, part of the Kaiser Permanente health system. It was the original Kaiser, turned 65 while I was a resident there, and it was built just outside the Kaiser steel plant in Fontana in the middle of nowhere. They couldn't get any doctors to come to the area, so they hired a doctor and paid him a salary. Built a 25-bed hospital, and that hospital was still there. You know, when you'd walk down that hospital, the floor would suddenly become hollow, and that was the old hospital, and then move on. So my experience there, not knowing it at the time, was quite illuminating in how to take care of a population. First, the physicians understood the cost. I knew that the average night in the ICU was $5,500. That it was about $3,000 in the step down and $1,500 a night in the hospital. And if you don't think that made a difference in the way you manage patients, then it did. Additionally, we had one formulary. I knew what the formulary was for every patient I saw and what was covered and not. Third is I had robust clinical decision support. Every year I had a family medicine packet that would come out. I would read it cover to cover. It was 75 pages long, and it was the most common diagnoses I would see as a family medicine doc. And it would say, here's the evidence for you. Each diagnosis is one page. Here's our recommended treatment algorithm. By the way, this is the cost, and these would be the reasons that we would treat this or this. Having the cost made a huge difference. The second piece is talking to populations. I could ask the question at any time and know exactly who my patients were. And we could flex up and down on populations based upon their acuity. If a doctor was going half-time, they managed that volume demand to availability to physicians quite well. And when I moved here 5 years ago, there was no clue. We had no clue. And to a certain extent, we still don't, although we're getting there, how many patients and who my patients truly are as a primary care physician. Between the cost, being able to actually manage a population, and then having that robust clinical decision support, I think that was the key differences that a Kaiser-trained doc would get, as opposed to, say, our fantastic family medicine program that we have here, not to put it down in any way.
Jim, you had a question?
Yeah, I do. We've heard a lot about our mission is to improve the health of the people in this region, and I think we've acknowledged we do a great job with sick care, but probably not as good a job on the health side. We heard from Beth, 51% of people's health is determined by their choices that they make, their lifestyle. We heard 85% of this is out of our traditional realm of doing things, so that could be kind of daunting. I'm a little like Tom, you can be terrified or excited. I choose to be excited on this. I think there are opportunities, but three populations where I think we have a great opportunity. Schools, kids are there, influence these kids at a young age. Child care centers, youth sports is kind of ubiquitous in our community. What are we doing to influence those populations as a kind of a population health, and how do we make a financial case for that, I guess? And then kind of a last question to make it even easier is, what's our role in trying to move policy in this country to support the kinds of things that we're trying to do? So I'm sure that's easy. One of you can do that in 30 seconds, but
Those are all easy questions.
Thanks.
Who wants to field those?
I'll jump on that one, and then I'll try and quit talking so much, so I apologize for that. I'm going to throw my brother under the bus, who's a civil engineer by training and got his master's in environmental, and we have that conversation quite a bit. If you go to Europe, There are big incentives to be physically active throughout your day. So you don't get up and get into your car unless you make a lot of money and can afford it, but generally speaking, most people ride their bike, take mass transit, they don't drive their car to Walmart, they walk down to the corner store. It is building an environment that is both safe, but also encourages good choices by the patient. Physical activity, making healthy food available in where people live rather than making you drive to one or two locations for large communities to do it. So I'm just speaking off the cuff on the conversations he's had. That's from an engineer's standpoint, it's all about design. You just design a community so that it encourages that type of behavior. Now, you know this, I'm sure, better than I do, but sports participation is down. It is down in this country, and you have this group of kids who are exercising in a sport-specific activity 12 months a year. They're specializing at a very young age, less than age 12. And that's quickly pushing out a lot of people who may just do the sports for fun because now it's no longer fun, it's a job. I would actually look to our community to answer that, frankly, is how do we build a community where we don't just encourage being physically active, eating healthy, but we actually make it, rather than an exclusionary item, an inclusionary item.
I think some of this is the application of the resource that we have available for healthcare and trying to figure out how we reallocate some of those things into this idea of the population health. Chris, you want to comment just briefly on the power of the community health needs assessment and some of the pieces that come in that at least help focus some of the available resource, maybe from the Luke's system perspective, towards some of these things?
Yeah, I'll comment briefly, and I think, Jim, maybe to answer, this isn't the answer, or I don't have the answer, but at the end of the day, we've got to align our incentives. And today, we look at some of the work that we're doing, and I know Kristen Armstrong, for example, was here yesterday, part of this session, and she's leading efforts in the community of STAR and at Bogus Basin and our athletic training and concussion programs. We've got a number of people out there doing great work that, frankly, we have zero financial incentive to do today. We do it because it's the right thing and we're giving back, but until incentives are aligned in such a way to encourage partnerships with not only St. Luke's Health System, but others, because we cannot solve the additional 85% on our own, we're going to be treading water a little bit. But I do want to comment on this community health needs assessment because it talks a little bit about what we're doing on our governance restructure and why we're organizing ourselves around the populations that we do serve. We have a community health needs assessment. We've executed that in every community that St. Luke serves. We've identified the top 5 healthcare priority needs identified by our community members, grouped into the areas of weight loss, nutrition, weight reduction, diabetes, access to services, screening and education. I can't remember the 5th one now.
Mental health.
Mental health. Gosh, how can I forget mental health? In any event, they're the same health needs in all of the communities that we serve today. And our reorganization, particularly with the implementation of our community boards, is going to be the engine, if you will, that ensures that we're matching the community need with the mission that we're doing. But I predict that we're not going to get the traction that we need until we align the incentives in such a way that we do have not only a financial but also a clinical incentive to really be out there engaged in the community more than we are today.
Gary, you had a question?
Chris said what I was going to say.
Sounds like the mentor-mentee.
Gary taught me that answer, by the way.
Just a couple other comments. I agree with Jim, and we got to do the analytics. We can't do everything for everybody, and we got to be successful at some things and then go on to the next thing. But if you think about the school population, if you think about child care population, it's a population like Geoff was talking about that we can execute on. We got to be sure we can do it. We got to do the analytics. But that's the beauty of what we've done, I think, with our governance structure. Just think of the commitment we've made. Just think of the commitment we've made to these community boards to be the tip of the spear relative to helping us figure out the partnerships, the relationships, the focus of attention to improve the health of our communities. We need to get behind that and drive it home, because out of that will come relationships that make us all more productive in what we're trying to do to improve the health in our communities.
Mark, go ahead.
Yeah, I appreciate the very thoughtful comments from my colleagues here as well as the questions. You're touching on the challenge of trying to address public health needs through an acute care health system. And we have cycled through that effort several times over the last 20 years. You as providers, but also your health plan colleagues, still really do function in an acute care delivery system mode. And it will always be challenging to fully embrace right out of the gate public health initiatives. That said, your focus working at the community level is critically important, and it's what I maybe was a little vaguely alluding to when I mentioned earlier, advancing the community conversation. In Minnesota, we've started to put coalitions together around activities that we've called accountable communities. So rather than accountable care organizations, think of accountable communities. Brought together civic leaders, nonprofit leaders, health leaders from both provider systems as well as health plans at a very local community level to discuss what are the health needs of that community and how are we going to advance them. I've sat in a variety of those, and you can imagine how impactful it is when the small business owner from small town Minnesota Main Street looks at the local hospital CEO and says, your costs need to come down, they're destroying my business. And then we also turn and look at the local grocer and talk about the accessibility of healthy food options and how to make healthy food options more affordable. And all the conversations then, right, that can spin around from that. So I do think part of your leadership challenge is to embrace these conversations at very local community levels as well as at the statewide level, for which out of the gate, there's not going to be a financial model that drives it. It's not going to necessarily be there, but it's your activity for the long play. I'd also like to make just one other comment, because I think Geoff described very nicely the relationship with payers and the emphasis that several made about trust. What lives in there, except maybe coming at it from a slightly different angle, true clinical integration does not begin to occur until you accept risk. You'll make progress on clinical integration, but the real drive into it will start to occur when the organization is taking risk. Be careful to separate insurance risk from health management risk. What the payer is looking for you to do is accept health management risk. Maybe it's a trite example, but Geoff alluded to it earlier. If Nexium really isn't helpful, stop using it. If you don't really need to do the back surgery, don't do it. The payer doesn't expect you to carry risk for the unexpected cancer diagnosis, for the unexpected car accident, the unexpected stroke. That's, a lot of that is insurance level risk. But once the conditions arise, you're accountable for health management risk, which really does benefit and drive from that very strong clinical integration activity. And it's your willingness to take that health management risk that will engage the payer now in a really committed financial arrangement that can help you drive more value-based, value-based opportunity.
We're winding down here with the last 5 minutes or so. Other questions in the audience? Kurt.
For Dr. Werner, in regards to the health management risk, you've been in a pretty mature market in Minnesota, and we are trying to find a way to work with our independent providers that are clinically aligned, and also with providers that are employed in the St. Luke system. And can you give us any advice on how you would develop an incentive funds flow methodology when we're still in a fee-for-service reimbursement system, and yet we have to find a way to reimburse physicians for some of the savings that we might realize? And is that done as a withhold, or is that done on top of the fees that are generated?
Thank you for another easy question. I enjoy talking about physician compensation and reimbursement. It's always like the third rail of everything, right? So a few comments, and they are just on the basis of my own experience, right? So I'm not going to profess to what I'm going to say in the next 30 seconds is your answer. But I think there's been a lot of effort at integrated physician network development across the Twin Cities, a lot of it, by multiple health systems to try to get there. It is far easier to understand the economic relationships between the network and primary care physicians than it is specialty care physicians. Gain share and value-based payments, population-based arrangements, attribution or otherwise, can very logically flow to the primary care relationship, to the management of a primary care panel, et cetera. It is exceedingly more difficult to figure out how to drive value-based payments to specialists, particularly in the early stages when the number of attributed patients and members involved remains small. So therefore, for any one specialist, it's a handful of patients that they encounter that were in that arrangement. You know, unlike the primary care physician where it could be a substantial percentage, a plurality at least of my panel, if not even a small majority of my panel, depending on the circumstance. So one advice I would have is obviously one size never fits all. As you think about physician engagement, both employed and independent, think separately, primary care versus specialty care. Specialty care will more likely have to be engaged in other ways, be that bundle payments, be that specialty care medical home arrangements, be that co-management arrangements. Particularly co-management arrangements, I think, are good early playgrounds with specialists that engage them in the management of the clinical operations to drive to efficiency, better clinical choices, the whole clinical integration piece. You're going to have to go there more with subspecialists, I think, than believing that there's going to be an end-of-year value savings distribution model that will work for specialists.
Seems to me
Did that answer your question, Kurt?
Seems to me what underlies a bunch of that is this idea of physician engagement. Jim, Steve, you, Brian, want to weigh in a little bit on, you know, the process and some of the challenges associated with physician engagement, because to that point, it is, you know, this huge sort of undone work to get at.
Thanks. Yeah, it's going to take a tremendous amount of leadership on all of our parts. And I think in the engagement of the independent community, the first step is actually, you know, I think the nature of the relationship today is a little bit of arm's length, and in between that distance is some fear. Fear has filled the void where trust should be, and we have to rebuild that trust. I think the cause for that perception in conversations I've had, it's several things, at least three, maybe four things. One has to do with just volume and the perception that when a clinic is acquired, so I'm going to talk about the issue, the perception, and the reality. The perception is when a clinic is acquired, that we then direct referrals inside the clinic. And, you know, I got to testify about this one in court, so I know it's true. We do not do that. But the perception is that occurs, and perception is reality. So you got to deal with that in rebuilding trust. I think there's also the perception of an uneven playing field, that when a physician group joins the St. Luke's Clinic, that, you know, our practices are more supported financially. And, the fact is, in my VPMA role, I'm the guy who tries to, work out ways to financially work with independent physicians, and it's darn hard from legal and regulatory perspectives. No matter what people say, oh, you can do it, it is much more difficult, and we have much more latitude within that employment relationship. So, that's a barrier, and I think it's a legitimate one. And then I think the third big issue is the perception of loss of influence, loss of voice. And again, it's not the reality, but the perception is that the organization is going to elevate the voice of the employed and de-escalate the voice of the independent. And I can tell you there is no intent to do that, but that is the perception, and perception is reality. I mean, we have an independent medical staff. Any member can run for office. We've got a physician leadership forum at the network. We've got PLCs that have subcommittee structures that are almost 50% independent, but that is the perception, and the perception is the reality. So, I think trying to overcome those things, there's some important steps, it seems like to me. One is elevating the voice of the independent. You do that through governance and structure. And the reason for that is, one, it makes it clear what's the connectivity to the organization, to the network. What is the pathway of communication? And then second, it puts independent and employed physicians in the same room together working on our combined clinical work. It builds relationships. I think another tactic is to be explicit in referrals. And what I mean about that is that whether we write it down or, in our EPIC system, that referrals are based upon the network, right? That we want our patients to go to those providers who, like us, are willing to go at risk, share their data, and be accountable for that care. And when we do that, I think we actually change the nature of competition, right? Competition now is based on our collective work, not on winners and losers and who's on the blue team and who's on the red team. It's based on the quality of our work. I actually pine for that day. I think the St. Luke's Clinic can be a center for innovation. It needs to be. I mean, frankly, because we have the latitude within that employment structure to be more creative in how we incentivize physician work. So that was a lot
Thanks,
of
Jim.
rambling.
Please help me in thanking our panelists for contributing a little bit to the night. Thanks, guys. I'd like to turn it back over to Dr. Pate for a couple of closing remarks and then to disband us. So thanks.